Hello and welcome to another Pipe at Pearl. Today's Pearl, we're going to be looking at the common cold. So like usual, we'll start with some facts about the common cold. The common cold has intrigued physicians and the general population for centuries now. There's literature going back well over 100 years on the common cold. It has been defined somewhat recently as an acute epidemic respiratory disease which has strong characteristics of what's known as coryzal symptoms. Now they include your rhinorrhea, your nasal obstruction, and your sneezing. The common cold is known as the most frequent acute illness in the industrial world. Now, theory is why it's not worldwide is quite frankly because they don't have enough data outside of the industrial world. There's no place for people to go and line up to go see clinics and get care in the third world. So 50% of the population of the industrial world have the cold at least once a year. Okay, but the average of colds is about 4 to 10 for children per year and 2 to 4 for adults. Okay, so those people that get it generally get it more than once as well. Of all the time that adults take off work for sickness, 40% of that is contributed to the common cold, and kids taking time off school, it's 30%. Now, the Americans love to weigh up the costs of illness and how much it's costing, and they estimate that about $2 billion per year is spent caring for patients with the common cold. Now, when we look at pathophysiology, again, as you can imagine, there's a few lines of pathophysiology because there's a bunch of suspects that cause the common cold. Now, when people define the common cold, and it actually is the common cold, it is viruses that cause the common cold. So the most frequent etiology agent is a rhinovirus. Okay, now that rarely causes anything else more serious than a common cold. Now, different studies have shown that between 10 and 40% of the time, a rhinovirus is the one that causes it. Now, there's over 100 different types of serotypes that can cause an illness in humans, but every study they do, generally over a period of time, seasonally, regionally, they only ever find between 14, 7, 8, 10 different strands of these rhinoviruses that are causing the actual problem, which, as you could imagine, makes vaccination very, very difficult for different regions. Now, the second most common cause of all the colds is coronaviruses. Now, that's not the classic COVID-19, okay, even though it's had a lot of publicity. There's a whole bunch of coronaviruses that cause the common cold, and they account for about 20% of the time. The third most common type, even though it's a little bit different to the common cold, is caused by influenza type A. Now that obviously gets classified as influenza, but it tends to start in that same category as the upper respiratory viral infections. We have the parainfluenza, which accounts for about 12% of the time, and RSV is also pretty popular, especially amongst the kids. But regardless of how it starts, it always starts with a primary infection of the nose. So the pathological changes during the development of a common cold, it begins with edema, and it's edema in the submucosal layer. Now, the first change that appears is the epithelial layers of that mucosal lining separating because the cells are becoming oedematous. And the surface cells loosen and then begin to slough off, and that's what causes the mucus production. Okay, it's obviously aided by a bit of moisture from your body, but that's what causes the mucus production. Now, the entire epithelial finally all breaks down, and later in the disease, the cells begin to regenerate, starting with the base membrane first. So that's why you can keep getting these sloughing, runny nose for a period of time. Now, the epithelial cells of the nasopharynx have intracellular adhesion molecules. Now, these molecules basically means that the rhinovirus can enter them, whereas the nasoepithelial cells don't have these receptors. So the ones around the nose don't actually get affected by the rhinovirus. So the rhinovirus often causes problems further back in the nasopharynx towards the sinus cavity, which is why you get that runny nose and the congestion aspects of it most of the time. Now, rhinovirus causes minimal, very, very minimal destruction of the actual nasal mucosa, and you get more of that congestion feeling. As the illness progresses, we start to get more characteristic signs and symptoms. As this viral infection matures, the symptoms are very similar to what's found with allergic rhinitis and some chemical irritations of the upper airway, which makes our differential diagnosis and our clinical examination very important to make sure it's not something else. Once the viruses are in and causing those pathological changes and tissue damages, it starts to release leukocytes and other cells. Recent evidence has indicates that a virus may even have the capacity to directly result in the release of pro-inflammatory mediators from the macrophages, the neutrophils, even eosinophils, and obviously your mast cells. And this causes a bunch of substances to be released, okay, like your histamines, which causes your vasodilatory response and obviously increases the congestion feeling and the actual runny nose as well. But it also releases your bradykines. Now, bradykines are a very, very potent inflammatory mediator that cause vasodilation. The reason it's important is sometimes antihistamines work really well because of the histamine response from the basophils and mast cells. But if the runny nose and congestion is actually caused by a bradykine release, then your antihistamines are going to be quite useless because it has no effect. So mast cells, basophils release histamines. RSV, rhinovirus, and parainfluenza are most common causes for the release of histamines, whereas other viruses release the bradykines. When we have the release of a substance known as interferon, that involves a pathogenesis in a recovery form. Okay, so interferons are used naturally in order to recover from viral infections. So an interferon is produced when a host cell, such as a macrophage, is stimulated by a viral infection or another signal from a different chemical mediator. Now, some viruses are very good interferon stimulators, whereas other viruses aren't that good. Influenza, parallel influenza, very good interferon. That's why you generally get a fever associated with them as well. Whereas your adenovirus, herpesviruses, things like that, they're not very good at releasing interferon, which is generally why we need to use antivirals for those ones. Now, the antiviral actions of interferon is mediated by a time-related contact with the host cell. And this period of interaction is necessary for the synthesis of that antiviral protein. Now, when we move down and we start looking at the actual primary infection, we start to look at IgA, there is a direct link associated with the amount of antibodies that people have and what sort of cellular response occurs during the common cold. So if somebody has a low amount of antibody, especially IgA, now remember from Anat and Phys that IgA are the dimers that sit in the mucosal area used as a primary antibody against respiratory and mucosal infections. Now if you have a low amount of those, what they've actually found is the antibody will bind to the virus, but then it will be more susceptible to be picked up by the cell because the antibodies can bind to the cells nice and easy with their other receptor sites. Okay, moving on to our actual examination. We always start with subjective data and we use EPSAN if you choose to. So we always get the event, and our main goal in getting our observation and subjective data is to find if it is a common cold. If it's a common cold, then we're nice and happy, but if it's not, we need to treat something else, and obviously we need to find it. So we let them tell us the event and we listen for clues. When we're looking at previous history, we want to know what sort of irritants they've been exposed to, what sort of social history they have. The common cold is very, very social. Therefore, it obviously can cause a lot of problems in communities. So families will have it, all schools will have it, classes will have it, that sort of thing. So social history can be very important. And when you're getting a medical history, you need to ask closely if they suffer from asthma, because allergic rhinitis and the common cold can be precursors for asthma. When we're doing subjective questioning, we basically just need to figure out how bad it is. So what are the associated symptoms? Okay, because certain things are quite rare when you're dealing with the common cold compared to other viral infections. Okay, so things like fever, muscle and joint pain, that sort of stuff is not very common when dealing with the common cold. Things like rhinorrhea, headaches, sore throat, very common. Okay, so you can narrow it down. How long they've had it can be an indication of the progression of the virus. And we also have certain rules, like if you've had congestion for greater than 10 days, then we can start to think about maybe it's sinusitis and maybe it's a bacterial infection. We also need to know what sort of impact this cold is having on their life. Some people will have the common cold and it doesn't actually affect them that much. Other people will get it and they'll be quite useless thereafter and need a lot more support. Looking at allergies, we obviously have to find that close link with hay fever and that allergic rhinitis aspect. Now, if it is just allergic rhinitis, someone just has a runny nose, it often is caused by allergies, but it can also have a sidebar cause from parasympathetic system overstimulation. Okay, but that's not as common. Now, medications that cause a runny nose is overuse of oxymethylzolines and other decongestants. It has a very strong rebound effect. Most of your antihypertensives, your aspirin obviously has a strong link with your asthma, and also OCP, but generally if someone started an OCP recently. When we move into objective examinations, our goal is to rule out everything else. It's almost like using the common cold as a diagnosis of exclusion as opposed to jumping right to it without doing an examination. So vital signs are vital, hence why they're called that. So we've got to do them. If they're a fever, we obviously up the ante in our treatment. We check out lymph glands. Now, if you've got the common cold, you will have lymphadenopathy most of the time, but they're mild and it's not painful. If they're really enlarged and they're painful, then we start looking at other things like Epstein-Barr, that sort of stuff. Now, the classic characteristics of nasal discharge when you're dealing with the common cold is the first 2 days, it's going to be clear discharge. After the second day, you can start getting a purulent discharge, which most people contribute to bacterial, but it's not. Just because it's purulent doesn't actually mean it's a bacterial infection, because the same leukocytes that kill bacteria also kill viruses, which give you this pussy looking mucus discharge. Now, as I mentioned, 10 to 14 day mark of this congestion and runny nose, we can start considering bacteria from a runny nose alone. But obviously if you have other contributing factors, or if you can take a swab, it's more relevant and you can give antibiotics for it. Okay. Now we need to inspect the mouth and the throat. And the reason we do that is because we want to rule out pharyngitis, laryngitis, tonsillitis, quinsy, Epstein-Barr, all those other things that cause upper respiratory tract infections. Okay, so if you have a common cold, your mouth will be very unremarkable. Tonsils will not be inflamed. Your back of your pharynx will not be red. There will be no ulcerations. It will be pretty much clear. As to lung sounds, at best, the common cold can cause some slight raunchy, but that's often associated with the upper airway. So if you get the patient to open their mouth as they breathe in, you don't hear the raunchy, it's more likely the common cold. Now, as mentioned, most of these findings are pretty much nil or very, very mild. If it's not, then start thinking that it's something else. And we do that when we think about our assessment. Our assessment is only, do we think it's the common cold? What else could it be? And if it is something else like allergic rhinitis, is it going to change our treatment? If it's not, then we move straight on to our actual treatment phase, which is where things get very, very interesting. Okay, because treatments for the common cold pretty much involve a huge list of textbooks and folklore and all sorts of things. So Starting around the top, we'll start looking at the medications, because there's been a strong belief that antihistamines reduces rhinitis and obviously can help with the common cold. And it can, but as mentioned, the runny nose and the symptoms can be caused by bradykines as opposed to histamine, so sometimes it doesn't work. So by all means, try them, but don't actually have uh, huge faith that they're going to work, because they even invented medication because it's big, big money in common cold. So they invented medications that are anti-bradykins, but unfortunately, they didn't work because they didn't work on the patients that had histamine release. So it's one of those ones. It's hit and miss. So what they've done is they've combined antihistamines with a combination of decongestants and analgesics and all sort of things, to the point that there's well over 1,000 over-the-counter products that are for cold and flu symptoms. Like I said, big, big money. Now, most of these were done and reviewed in a study, and they found out that most of the over-the-counter medications don't do anything at all for most people. Okay, so they found very little evidence or no evidence of effectiveness from over-the-counter medication in children, and mild effects or benefits in our teenagers and adults. They also found that when applied nasal spray or taken orally, most decongestions had positive effect at reducing nasal stuffiness. Okay, so your nasal sprays are the best. However, there is a massive problem associated with rebound congestion, and that often results from rapid withdrawal of the decongestion or overuse of it. There's also huge risk associated with people that have hypertension, so it needs to be used with caution. When we look at our NSAIDs, our aspirin, our paracetamol, they also didn't perform very well in studies. If anything, they actually tend to prolong the duration of the viral shedding. So they actually can cause the illness to go longer by taking it. Now, if your patient wants to take it because they're in pain, then obviously let them. The duration isn't that much of an increase. Okay, so there's your pharmaceutical lines. It's if you're used to taking something and it works, and your patient's used to taking something and it works, let them have it safely. Okay, but don't put much stock in it. A cold will be a cold most of the time. When we move to the other side of the fence, the old alternative therapies, depending what it is, there's mixed results there as well. So you can get entire textbooks on folk remedies and natural therapies for the common cold. Numerous of them are associated with heat vapor or local hypothermia, so warm gargles, that sort of thing. Now, nasal hypothermia or breathing in of steam has actually been shown to be very effective when dealing with nasal congestion. Now, I know you will find studies out there, mostly from the pharmaceutical companies, that says that it's not, but there are big meta-analyses that show that it helps, even to the point that they believe that the old chicken soup is actually, the benefits come from, well, one, you're eating, replacing salts and that sort of thing and getting hydration, but also because of the steam coming from the soup that you're breathing in. Now, if you've heard of using zinc, zinc has worked in children, but when you use high doses very, very early, it pretty much stops it. When you use low doses, or doses that's small because people are adults, it's not very effective. As to with echinacea and vitamin C, some really early studies says that it was great because of its antioxidant effects, but further analysis says that there's minor influences, that sort of thing. So the biggest treatment realistically is drinking plenty of fluids, keeping your hydration up. It's always a good idea in life, and getting plenty of rest is also a great idea. The use of vapor rubs, if people like those, can help much with the inhalation, but has a long list of adverse effects, more so than the treatment. So as far as the adverse effects go, we're talking about local skin irritation and burning. So if your patient can handle that, fine. maybe not consider it an adverse effect. But a lot of the time when you're dealing with children, the risks may actually outweigh the benefits you get from vapor rub. And the last one that I know you've all been looking at, which is a warm bath. Again, breathing in the steam can help, and it feels nice, like a rest. So knock yourself out. Bottom line is, do whatever home remedy the patient thinks. Don't fall into the habit of polypharmacy and loading them up with decongestions and antihistamines and NSAIDs and all these other combinations of medications, because most of them don't actually do anything for the patient. Okay, so pretty much only give them on patient's request, because as long as they take them safely, they can get mild relief from their cold symptoms. Stuff that you can do to really help it is provide education. Okay, so get the bloody patient to wash their hands. Okay, just because it's a cold, if COVID's taught us anything, is washing hands important. I know who would have thought that we needed a pandemic in order to teach the population that washing your hands is a good idea, but here we are. So wash your hands. Now, soap and water is much better when dealing with the common cold. Okay, certain viruses that cause the common cold, they're not really susceptible to alcohol hand wash, so soap and water is your goal. They're what's known as enveloped viruses, don't really work. If you have a low-grade fever, don't try to knock it away with paracetamol. Low-grade fever actually helps. Viruses spread easier if the body temperature is a little bit cooler. So a low-grade fever is there to help the body heal from the virus. Antibiotics are never ever needed with the common cold. You will get patients to go, every time I get the common cold, I end up with a sinus infection. I need antibiotics. And they say it all the time. And whilst it may be true, and whilst it may end up being that way, it's still recommended that you wait until it is in fact sinusitis, bacteria infection, so that 10 to 14 day mark, before giving it, as much as the patient may hate. If you can't convince them, obviously transfer them to the doctor. The doctor will make their own decision and go from there. Isolate the person as best they can. Okay, obviously they still have to live. It is the common cold. They can't take 14 days off work. Okay, but isolation is a good idea. The use of face masks, yes, it's not just for coronavirus. It can help reduce the spread of droplets from the coughing, basically. Now, man flu is a viable thing. I know it sounds really weird because I'm a man and I'm defending man flu as a thing. Okay, so it's a horrible term, very, very rude to marginalize it, because even if it's not as bad or a little bit worse than female flu, it's still diminishing the patient's feelings and symptoms by labeling it as really something that's known as a weakness. Okay, so men generally get sicker with the common cold. Now, the only reason for that goes back to that antibody response that I spoke about before, the IgA. Now, men will generally have a lower immune system than females. It's almost like females have a biological imperative to have a slightly stronger immune system to protect precious creatures that are growing inside them. Okay, but the man flu does affect it. So whilst the treatment's the same, try not to fall into the trap of diminishing it with your personal opinions. As far as restrictions go, physical restrictions are a good idea when somebody is sick with a viral infection. There is a link with viruses spreading to the heart, endocarditis, things like that, with overexertion once you have a viral infection. So no one really wants to run around when they're feeling that they have the flu. Sick leave is a good idea, but remember that these courses can last a long time, so consider the good old working from home if they can, much like they did in the height of the pandemic. If you have any remarkable findings in the subjective or the objective data, or if you think it's time to start considering the use of antibiotics, then refer them on to the medical officers, okay, to prescribe maybe some treatment that's a little bit long term. Okay, so that's the end of the common cold. It is excessively common. You will see it. You will hear all sorts of advice and remedies to treat it. What's the best thing for it? Across the countries, there's slightly different. Pharmaceutical companies are amazing at making medications that patients want. Educate your patient on the validity of those medications, okay, but don't die in the ditch if the patient wants to take something that is available to them, because it is available to them. Okay, the big thing that we do not hand out willingly for common cold is antibiotics. Okay, it was very, very popular at the start because it was used to cure the bigger infections that weren't the common cold, but it's also theorized the reason why we have superbugs and that sort of thing. Okay, so don't deliver, prescribe, or dispense antibiotics for the common cold just because the patient asks for it. And until next time, take care.